Okay, so am I audible to you all? Okay, thank you, Ikra. Right. So just let me make this screen visible for you all. Right. So, a very good evening, morning to all of you. And how is the preparation going on? It's about only 20 days left to the exam, right? So we just need to buck up. We need to buck up a lot more. And I can see I've gone through all of your names. I can see a few of my old students. I can see a whole lots and lots of new students who are here with me today. At any point of time, if you feel that there is any confusion, I would suggest that you feel free to open up. It's always an interactive session with me, and I would like to hear your thoughts as well. Okay. So we have got only about 3 weeks. So let's not waste further time and get into the preparation mode, get into the question solving mode. So I know that 3 weeks from the exam is a very crowded time when you are feeling a bit overwhelmed with all the amount of information that you're getting, and I do understand that because part two is an examination where you have to process a lot of information, keep revising it, and a few days before the exam it feels very much unthinkable, unimaginable, undoable. And that is why we do have a lot of solutions for you. So we had our mini schedule, we had our sessions, we had our mock tests, and now we are bringing to you our final ultimate workshop bundle for the batch of June candidates. We are going to have the EMQ boot camp, which is going to start on 15 June 2026 with Dr. Hassan. So EMQ is something which is going to keep people confused at times, because you often feel that maybe too many answers are pointing to one particular question. You often feel that okay, this is one question, and the next question is also feeling like the same answer, so you do have that kind of doubts when you're solving the EMQs, right? Okay, so I believe that the voice is okay for everybody. Right, so Aisha says that she can hear okay, fine. So um, for the EMQs, I would suggest that you take up the workshop with Dr. Hassan, because he is going to give you certain fine tunings about the how to solve the EMQs, what is the right approach to it when you look at a question, how to scan through the options and find the best suitable option for you so that you're not confused in EMQ. As for me, I have got the high yield boot camp, which starts from 20th June. And those are going to be live interactive sessions where we are going to take questions module wise, series wise, and we are going to clear concepts together. One particular difficult concept, which is, kind of very high yield for questions, is what I'm going to discuss with you. Okay, sorted, Andy? Yes, that's wonderful. So, how if you're one of my old students like Andy, Aisha, so then you would know that we do it in a way where I give you certain last look slides, and they're very power packed slides with lots of information, and those are the slides which you must revise before the examination. Okay, because it's going to be your compact last moment revision slides from where you can get a lot of information. This is one of my very dear students, Ariba, who passed in last January session. And this is what she had her thoughts on the bootcamp videos last time. So she was not being able to attend the classes, but she went through the videos in the last 2 days before the exam, and they were very helpful. And this was her first reaction when the results came out on February 13th, when she reached out to me over Telegram. So such moments feel wonderful, and I hope that we will have more of such moments with all the students that we have this time. So This is going to be a preview of what you can expect in the bootcamp videos and the workshops. So we are going to take up the high yield pockets of the exam preparation from where recent updates and recent changes have been made in the guideline. And we are going to discuss that so that your recent updates of the RCOG guidelines are, all covered so that you are not going to miss out on the information. Now, today, as a preview, I'm going to discuss certain important things which have come up very recently. So, one of them is NICE abortion care guideline, and that had been updated in May 2025. Now, amidst all of the things in early pregnancy care, at times we kind of tend to forget the abortion care guideline because it is about not only about the spontaneous abortions, it is mostly about the induced abortions where the patient is coming willfully to you for surgery. So how we are going to for abortion, I'm sorry. So how we are going to take up the class today is that we are going to discuss certain parts of the guideline, giving you certain last look slides which are high yield on information, and we'll also be solving questions together. In the boot camp, also it is going to be question answer based from those particular pockets of the exam syllabus from where repetitively the questions are coming. So, NICE abortion care guideline, of course, first and foremost thing that you need to have is a non-judgmental approach towards the patient. Waiting time. Now, this is one of the high yield areas. I've highlighted that. Suppose a patient has come to you and she is requesting an abortion. Okay. The initial assessment has to be done within 1 week of the request. Okay, because this is when the patient is coming, approaching the NHS services asking for the abortion service, and the first assessment, the first appointment with the doctor has to be within 1 week of the request. If it is not possible to have it on a physical consultation, even RCOG is allowing a phone or a video call if the woman is comfortable with that. And you have to provide the abortion within 1 week of assessment. So, 1 week of request, you have to assess the patient. And whenever you have assessed the patient within 1 week of that assessment, you have to provide the abortion services to the lady. So, the lady makes up her mind today, today being 10th of June, right? So, by 17th of June, you have to assess her. You have to give her the initial assessment, either physically or over phone call or video call. And by 24th of June, that is within 2 weeks of her making up this mind that she doesn't want to continue the pregnancy, you have to provide the abortion services to her. Okay, these are the small nuances while reading the guideline, which often tends to get you confused when you're answering questions from EMQ. Now, no compulsory counseling or time for reflection has to be provided to the patient before abortion unless the patient is particularly requesting for it. So, what the NICE or the NHS is actually wanting us to do is give patient centric care in a way that it is acceptable to them. And as soon as the patient makes up her mind to abort the pregnancy, we should not give her more thinking time, more reflection time, unless she asks for it particularly. Within 2 weeks, the service has to be completed. Okay, abortion is not associated with increased risk of breast cancer. Yes, not associated with infertility. Now, this is one of the things which often, we tend to counsel the patients that way, that okay, you're aborting a baby, maybe next time there will be problems. But NICE guideline, NHS is directly pointing out that abortion is not associated with increased risk of infertility as well. Okay, or even for that matter, mental health issues. So none of these are going to be increased if the patient undergoes abortion. So NICE guideline is very, supportive towards women wanting this kind of services. Now, antibiotics and abortion, what is your thought on that? Let me make the chat private if my old students would know uh, about this, and my new students wouldn't know. So when I make the chat private, all your answers are directed to me so that you're not, kind of influenced by others' answers. So what is your idea about antibiotics and abortion? Is it routine Or is it, routinely you have to give, or is it not routine? What is your idea? Routine or not routine? Okay. So I've got even more specific answers. Good. Andy, Lenovo, you are Nitya, yes, you've all gone through the guidelines. So, without a further ado, antibiotic use now prophylaxis is not needed. Okay, it is not needed for women needing a medical abortion. Okay, so we cannot say it's not routine. It is not needed for women having a medical abortion. But what about surgical abortion? It should be offered in surgical abortion. Okay, so antibiotic need not be given in medical abortion and should be offered in surgical abortion. So you see how, when you look into the guideline very minutely, things change, right? So what about the antibiotic that we are using? Which antibiotic? It's oral doxycycline 100 mg twice daily for 3 days. And yes, let me see who has given me the right answer. Rubina. Right, Rubina, very specific. I like your answer. Doxy 100 mg for 3 day in surgical. Yes, so Nithya also is aware of the concept. So yes, brilliant. So everybody is following. So which antibiotic is oral doxycycline? We know that. Then we have another thing which I want to highlight. There is no routine use of metronidazole. This you have to keep in mind. Now, what about thromboprophylaxis in abortion? Thromboprophylaxis, women who need pharmacological thromboprophylaxis, you have to consider LMWH 7 days after the abortion or 7 days. Okay. So today she has an abortion, 10th of July, 10th of June, up to 17th of June, we have to consider her for LMWH. And women who are at high risk of abortion, you have to consider starting before, and then you have to continue for longer time afterwards. Now, people who have been with me for the thromboprophylaxis, the VTE guidelines, my old friends, my old students who have been with me, you know that how much we have covered in detail about patients, where to use LMWH, where to use, how longer do we use when you're using that for thromboprophylaxis, when to use for recurrent miscarriage. We all have that in a booster slide in last look slide, right? So thromboprophylaxis, if it is needed pharmacologically, LMWH 7 days after abortion, and at high risk of abortion, we have to give it for a longer period. Now, anti-D in abortion. This is bringing out a lot of confusion among students that I've seen. So, the first and foremost thing is that you have to make your life simple. How do you make your life simple? It's just by looking at this particular blue box. This is the part in the NICE guideline, and when it comes to the anti-D prophylaxis column, it is directly redirecting us to WHO abortion care guideline. And that, as per 2025, has made a major change. Here they are telling that it doesn't matter whether it's a medical abortion or surgical abortion. They are telling that anti-D is not required for any abortion below 12 weeks. So please keep it in mind. Anything below 12 weeks will not be needing anti-D immunoglobulin. Any pregnancy, the moment it touches 12 weeks or if it is over 12 weeks, is going to receive anti-D. Right? So things are actually very simple. If you look over here, below 12, don't give. Over 12 or at 12, you have to give. And over here, I'd like to highlight where this equal to sign is there. So at 12 weeks, you have to give. Okay, so more than or equal to 12, you have to give. Just remember that. Let's solve certain questions very quickly in the chat box. 10-week, 1 day, surgical abortion, O negative mother. Okay, so yes, Harim, Andy, DK, Mary, iPhone. Whose iPhone, whose Lenovo, I don't know, but of course, no anti-D. Now, 12 weeks, medical abortion, B negative mother. 12 weeks. Okay, so yes, we will be giving this for her. Now, 12 weeks, 5 days, surgical abortion, A negative mother. Give or Don't give. Yes, we have to give. Very good. So moving on, the last scenario, 6 weeks medical abortion, EB negative mother. Right. So it's like fastest finger first. Yes. So you all are correct. You don't give. So this is the summary. 12 weeks or more than 12 weeks, you have to give. Less than 12 weeks, there is no role of anti-D. Now, because the exam we have found are becoming more and more image centric, they want to test your basic concepts. So that is why I don't know how many of you are doing your scans regularly. So I just thought, for the benefit of everybody, we do a quick run through how the ultrasound, you know, uh, how the ultrasound parameters are going forward. So, first and foremost, if it is between 4 to 5 weeks, if it is at that particular stage of development, there might be a small intrauterine fluid collection with rounded edges. Okay, this is a sac like thing which is just there, and this is the first picture that we'll have in 4 to 5 weeks. Now they have zoomed further within this sac, okay, within this fluid filled space, they have zoomed further. 5.5 weeks, they have found a yolk sac. This is the yolk sac. So this was the basic sac, and now they are finding the yolk sac. And once you find the G sac with the yolk sac within, then you are kind of convinced that okay, this is a pregnancy that is developing. Okay, alone and empty G sac, you might still be confused, but the moment you see a G sac and the yolk sac developing in between, you are kind of sure. Now, 6 weeks. In 6 weeks, you are going to look at an embryo developing. So this is the yolk sac. Okay, this circle is the yolk sac. This one is the G sac. And in between, something is developing. You can see over here, this is the embryo which is developing. And if you go down further, there will be in about 7 to 8 weeks the amnion that is developing. So this is the embryo now, and this sac is slowly engulfing the embryo from all sides and is becoming the amnion. So this is in short the story of early pregnancy if you follow it radiologically. Now, the problem is between true gestational sac and pseudo sac. Okay, what is a true gestational sac? You can see over here, this is one particular fluid filled area, and we can see a, sort of a hyperechoic ring around it. Can you appreciate that? This is a fluid filled sac, and there is a hyperechoic ring which surrounds it, kind of giving it a very definite prominent margin. This is a true gestational sac. Whereas a pseudo sac may not be entirely round, may not be covered on all sides with this prominent rim. So this is a pseudo sac. If we get a pseudo sac, we are worried about one particular thing. Can any one of you tell me which particular thing are we worried about if we find a pseudo sac? Very good, Andy. So, yes, Aisha, yes, Mary, DK, you all are correct. We would be worried about ectopic. Now, if you look at the diagram over here, they are also giving you a diagrammatic representation. So, you have to be very careful when you look at a scan picture, whether it's a true sac or whether it's a pseudo sac, because if you're anyhow confused, you have to look for the sac developing outside the uterus because you have to look for the ectopic pregnancy. Now, USG before abortion. So, what if a patient has come to you? If you've been with me for long, you know I have got a very favorite patient called Mrs. Adams, and Mrs. Adams comes with all sorts of gynecological and obstetric problems into our lives, right? Into our classes. So, suppose Mrs. Adams have come to you with this sort of an ultrasound picture, okay? And she is requesting an abortion. Now, I want the house's opinion, all of yours opinion. What would you want to do? Would you want to continue with her request, or would you want to, you know, not go ahead with the abortifacient? She is having a pseudosac. So let's see. You have read the guidelines, I know, but how minutely have you read that? because EMQs might get formed out of it. Okay, so I've got two of yours opinion. What about the rest of you? Come on, let's just make it interactive. Doesn't matter you provide the services or you don't provide the services. If she's coming with a pseudosac. Okay, so far I've got 3 candidates responding, 4 candidates, and they're all telling me that okay, she has come in early pregnancy. She is either ways wanting an abortion. Okay, and today I can see that there is only a pseudosac. We cannot see things further, but either way, she doesn't want a baby. She wants an abortion only. So, can we proceed? What would be the immediate next step? Immediate next step is to rule out if she has signs and symptoms of ectopic. So, now, if this scan has come up in Mrs. Adams and Mrs. Adams comes to our clinic and tells us that, okay, I don't want the baby. So the next step that I'm going to take is ask her if there are symptoms of ectopic. Is she having pain abdomen? I'm going to check for the symptoms and signs. And if she does not have those symptoms and signs, NICE guideline is telling us she can go ahead with abortion. But she needs a follow-up. And you have to explain to the patient the possibility of ectopic and give a 24-hour contact detail of the patient. So I know that you all have read the guideline, but see, what is the minute differences that actually changes your answer? So yes, you're going to provide the service to her after confirming that she is not having any of the ectopic related symptoms. Okay, it is not that today she is having a GSAC. If they give you an option like that go ahead and do a scan, repeat a TVS 1 week later, and then give her abortifacient. That is going to be the wrong answer. Or do a beta ACG and then provide the abortifacient. That is also going to be a wrong answer. You are just going to tell her that okay, do you have pain? You're going to clinically examine her and look for signs of ectopic. If they are not there, you can prescribe her the pills, but you have to explain her the possibility of ectopic, the need for follow up, and you have to give a 24-hour contact details. So you see, like Andy is telling that I missed this point. Thanks for pointing it out. So we know through our experience of being with students for so long that exactly which type of points goes missing when you go through the guideline. Okay, so this is there. Now about medical abortion. Okay, so I've got two last look slides. This is for surgical abortion and this is for medical abortion. So those two roses are completely different. I'm going to give you some mnemonics on how to and tips on how to remember them very easily. And what happens when you are reading this, repetitively, sort of all the numbers get jumbled up. Okay, so this one is for surgical abortion, this one is for medical abortion. So first we're going to go ahead with medical abortion. So see, up to 10 weeks, we know what drugs we are giving. We know we are giving mifepristone and misoprostol, right? Now, thankfully with mifepristone, there is no variation in dose. So God is kind to us. So mifepristone remains 200 milligram throughout. Okay, no problem there. So from 10 weeks up to 28 weeks or even further, it's 200 milligram. Now misoprostol. Misoprostol is where the dose variation is occurring. And also some variation is occurring in the time gap. Generally, the time gap up to 10 weeks would be 24 to 48 hours time gap. And after that, it is going to be 36 to 48 hours. So see, I've color coded them. So they are basically not changing that much. So remember this in a pictorial format so that whenever the question comes in the exam for you, it's easy for you to recall. Now, for misoprostol, we are repeating that, giving that 800 microgram PV. Okay, or we can give 600 microgram sublingually. Sublingual dose is always going to be lesser than the PV dose. Why is that? If you're in front of a mirror, if you just revert your tongue and look at your base of your tongue, you will see that there are very big prominent blue veins. Okay, So two big prominent blue veins. And what do? They have a rapid action. They will just quickly absorb the drug and make it work. But the problem is that if suppose the patient is allergic, if suppose the patient develops, too much of tachysystole with that, so all of that rapid absorption is not advisable. That is why whenever you are giving misoprostol, you give a little bit lesser dose than the PV dose. So 800 microgram if it is okay for the PV dosage. For sublingual, you will put a little bit lesser, that is 600 microgram. So it is or. Over here, please remember, please look at this. It is or. I know people over here are across various time zones, across various countries with various types of practices, and everything works, okay? Kind of any of these dosage schedules or whatever you do ultimately will work. But if you're appearing for your part two, you have to remember what is given over here because that is what the guideline is telling us. So it's 200 milligram mifepristone followed 24 to 48 hours later by misoprostol, and that is either 800 microgram PV or it can be 600 microgram sublingually. Now, the next thing is that can it be done at clinic? Yes. Can it be done in hospital? Yes, of course. Can it be done at home? Up to 10 weeks, night guideline is telling us it can be done at home. And there are certain special points that I would like to highlight over here. So, up to 9 weeks, even the patient can take the mifepristone and misoprostol together on the same day. But you have to explain to the patient that if you do that without this time gap, it will be less effective. Okay. Now, vaginal meso is always preferred over sublingual misoprostol. That is why I'll always put the vaginal meso over here at the top. Okay. Provide follow up at clinic or remote assessment unit by telephone or text messaging or with personal assessment. Okay. So, this is for below 10 weeks. Mostly we can expect questions from here, their real life scenarios from here. Now, if they twist the options a bit, so 10 to 20, 10 plus 1 weeks to 23 plus 6 weeks, we start with 200 milligram, then 36 to 48 hours later, it's 800 microgram PV or 600 microgram sublingually. Now, then what you want to do? 10 weeks above, there will be a formed embryo, a formed fetus. So you want the misoprostol dose to be repeated 400 microgram every 3 hours till expulsion of the fetus. Okay. Now, whenever the period is more than 10 weeks, you cannot do it at home. So remember that up to 10 weeks only we can advise the patient to carry this out at home. Beyond that, it cannot be done at home. If it's 24 to 25 weeks, MIFE remains the same. Meso is going to be a lot lesser. We do not charge the patient with the initial 800 microgram the moment she crosses 24 weeks. Why is that? Because the moment the uterus is more than 24 weeks, it becomes more sensitive to misoprostol. And the chance of developing a rupture is more. That is why we do not give the initial dose. We will just give 400 microgram every 3 hours till expulsion. That can be through PV, oral, or sublingual routes. Okay. Now the patient is between 25 to 28 weeks. So mifepristone and time gap remains the same. Misoprostol is something we are now even more cautious. So 400, we are now more scared. So 400 is becoming even lesser. It's 200. And 3 hours is becoming every 4 hours. Okay. So it will be again through PV, oral, or sublingual. Now, moment the pregnancy is more than 28 weeks, then we are even more scared. So 200 now becomes 100, and the time gap is going to increase because the bigger the uterus, more risk of getting overstimulated and more risk of rupture. So I believe that this particular slide is clear to you all. Okay, is it so? Right. So now moving on. This is for surgical abortion. Now you can see over here the gestational age is given over here and surgery is written over here. Okay. What do we do in between that? Before the surgery, what are we going to do? So we have to prime the cervix. Why? Because I know all of you have carried out such procedures, so you know that how important it is for the os to dilate, because it makes our life simple, it makes our life easier, and that is why cervical priming and the dosage are going to be important. Over here, you see, it can be a 400 milli. If it is below 13 weeks, 6 days, then you can either use a 400 microgram misoprostol sublingually or per vaginally. Okay. So if you use it sublingually, please note over here, if you're using it sublingually, you have to put it sublingually 1 hour before the surgery. Sublingual 1 hour before the surgery. If you're going with a PV misoprostol, you can put it 3 hours before the surgery. Why? Because you already know sublingual works faster, there is a rapid absorption, so you can put in the sublingual meso now and do the ot 1 hour later. But for a pv meso it will take 3 hours for the os to open. Or there is another option, you can put in a 200 milligram mifepristone orally, but that has to be given 24 to 48 hours before. Okay. Now, the next group is 14 to 16 weeks group, where another variable is getting added. That is called the osmotic dilators. Now, what are these osmotic dilators? These are like very small matchsticks with a tail attached at the bottom. So, these matchsticks are going to be inserted inside the os. Right, Aisha, it's the laminaria tents. So, they are going to be laminaria tent is like a particular type, and osmotic dilator is the family to which the laminaria tent is belonging. Okay, so anything which is like a matchstick, there are various types available. So these are the osmotic dilators. If they're inserted within the os, they slowly dilate the os. So it can either be the osmotic dilator or misoprostol PV sublingual or oral, or 200 milligram misoprostol, and it has to be given 1 day before. Because why? It's a 14 to 16 weeks baby now. 16 to 19 weeks, you do not use mifepristone. Over here, you're either giving osmotic dilators or misoprostol, right? And after that, 19 weeks to 23 weeker, over here 1 day before, you are putting in osmotic dilator with 200 milligram mifepristone. Why don't we combine osmotic dilator with misoprostol? Because osmotic dilator is a matchstick kind of a thing which you're putting inside, and in case you are giving misoprostol, there will be hyperstimulation, there will be contractions of the uterus, and that might bring about rupture. Sorry, not rupture, perforation. Basically, in the cervical canal, the osmotic dilators are placed. They go on imbibing the fluids from around, and they go on swelling in size. And if the uterus contracts upon it, there is a chance of perforation. That is why, look over here, do not offer misoprostol if osmotic dilators are inserted. Okay. Now, local anesthesia. Local anesthesia means the least hospital stay. You can also combine IV sedation with local anesthesia for patients if they are anxious. You can also opt for deep sedation or general anesthesia with IV propofol or short acting opioid like fentanyl, because they will not be, if you give this sort of a combination, deep sedation or general anesthesia, the patient is not at all going to be um, you know aware during the procedure about what all is happening. Okay, so Rubina, okay, so why we are not giving misoprostol and osmotic dilators together? So osmotic dilator, you see, it's like a small matchstick which is getting inserted inside the os. Now it is absorbing water from all around. They are doing osmosis, right? So absorbing water from all around, and slowly this matchstick is swelling in size, and that is like a very big stick inside the cervix. Now, if misoprostol, what does it do? Misoprostol's main mechanism of action is to generate contraction. Now, if it is generating contraction, what is going to happen? If it is contracting on the osmotic dilator, which is there in the cervix, it might lead to perforation of the cervical canal, or if it is a bit longer, then might even of the posterior wall of the uterus. So all of these perforation risks are there. That is why we do not offer misoprostol with osmotic dilators. Is it clear to you all? This particular last look slide. Okay. Okay. Thank you, Rubina. Thank you for giving the heads up. Now, aftercare, what do you need to do? So questions may come out of here, and it's something very basic. Medical abortion, they need to have a low level or multi-level urine pregnancy test later to exclude any ongoing pregnancy. If you are doing a medical abortion, if it's a surgical abortion, you can actually see that the tissue has come out. If it's a medical abortion, we are not sure, even at certain points, what was the cutoff where they can do it at home. Medical abortion, do it at home. What was the cutoff, please? Medical abortion, doing at home, cutoff is 10 weeks. Very good. So the cutoff is 10 weeks. So you never know whether she had passed the fetus, whether she has not passed the fetus in 10 weeks, right? At home. So that is why you need to repeat a low level or multi level urine pregnancy test to later exclude ongoing pregnancy. Along with that, of course, emotional support and contraception. Now, look over here. Implants and IUDs can be offered on the very same day of taking the mifepristone. Okay, even before the medical, misoprostol dosing starts, you can put in the mifepristone. You can put in the mifepristone and the implant on the very particular same day, right? Even for IUD, you can put it on the day of the surgical abortion or after expulsion of medical abortion. So, of course, you cannot, put the IUD before. After expulsion has occurred for a medical abortion, you can put in an IUD. That is kind of common sense. Okay, no need to kind of memorize these things. These are kind of common sense. For IUD, it's of course normal that it's logical that we are doing a surgical abortion at that particular sitting, we are inserting the IUD. And if the patient is having a medical abortion, you have to wait for the expulsion of the products, then only you can insert the IUD. But implants is what you need to remember. Over here, your, memorizing things are important. So, offered on the day of surgical abortion or the day of taking mifepristone. Okay, and DMPA. Now, DMPA you have to consider taking on the same day as mifepristone. They might formulate an SBA like this, right? Where they might ask you to choose which is the wrong answer, which is the incorrect statement. So always remember, if you are giving mifepristone today and you have prescribed the patient, Mrs. Adams, that okay, today you're taking mifepristone, today is Wednesday, on Friday you take the misoprostol. So, if Mrs. Adams is wanting the implant, would you put it on her on Wednesday or Friday or even later? Are you following the question? Listen to me once again. Mrs. Adams have come to you. She wants an abortion. She also wants an implant. Today is Wednesday. You are giving her mifepristone. You're planning to give her misoprostol on on Friday, and when do you plan to give her this implant? So, as per the NICE guideline, she can receive the mifepristone and the implant on the very same day. The implant will not hamper the action of the mifepristone. But this is the difference when it comes to DMPA. Please memorize this. Okay? Whenever Mrs. Adams is coming to you and telling you that today is Wednesday, I want to abort, I also want a DMPA. You do not recommend her DMPA on the very same day. You consider, recommending. Why consider? What is the difference between offer and consider? I know you all know offer means it's 100% recommended. Consider means it's a risk versus benefit evaluation. So you have to consider taking on the same day as mifepristone because it may hamper its action. So this is the point which you have to memorize. Of course, with IUD, you don't need to memorize anything because it's all common sense. Is it clear up to here for all of you? Okay. So another thing from where questions are coming would be the abortion laws. Okay. So abortion law is where there are the different clauses in place from where the questions they might be placing. So you remember clause A, B, C, D, E, F, G. And don't get confused when the questions come. Remember A, B, C, D, E. Up to E, there are different rules. F is going to be clause A in emergency. G is going to be clause B in emergency. Okay? Whenever there is an emergency, look over here. Only one doctor's opinion is okay. So, clause F, clause G, one doctor is sufficient, and this certification has to be given within 24 hours. That is the certificate B. That needs to be submitted within 24 hours. But if it is clause A to E, you have to take two doctors' opinion and you have to give a certificate A. Right? So, life risk to mother. If the pregnancy is such that there is a life risk to the mother, then it's going to be clause A. And that has to be verified by two doctors and certificate A has to be filled. Clause B is where there is grave permanent injury to the physical or mental health of the mother. Again, the same parameters. Clause C is where there is injury to physical or mental health of the mother up to 24 weeks. So, up to 24 weeks for causes which are causing injury but not grave permanent injury, you can take the patient up for abortion. But beyond 24 weeks, clause C is not going to apply. Beyond 24 weeks, if you have to abort for the mother's sake, then it has to be something so serious that it is causing a life risk to the baby, to the mother, or a grave permanent injury to the physical or mental health of the mother. So you're understanding that though there is no upper limit given, but the UK law is very stringent that beyond 24 weeks, if you are carrying out an abortion, it has to be for very strict indications. And that has to be a life risk or a grave permanent injury to physical or mental health. But any other thing will be clause C, where there is an injury to the physical or mental health of mother, and that is up to 24 weeks. Clause D, over here between D and E, again I find students getting confused. So D is for injury to physical or mental health of any existing children of the family. Okay. So, and that family has to be the family of the mother. That is another subtle thing that you have to remember. Okay. So, if suppose there is a sibling and the sibling is affected with a Down syndrome or something like that, which is making the sibling, or autistic, which is making the sibling dependent on the mother for care. Even mild autism is not a problem, but with autistic dependent on the mother, and taking another child is going to be very difficult for the mother. That is why it is going to be clause D, that she cannot take the pregnancy because of the problem of the existing children that she already has. Clause E is about problem with the unborn child. That is any problem with the fetus, with their development, with their anomalies. That is going to be clause E. So are all the clauses clear to you all? Because now we are going into practice questions, and I hope that things are clear to you. So life risk is clause A. If it is clause A in emergency, it will become clause F. Grave permanent injury to physical or mental health of mother is clause B. If it is an emergency, it will become clause G. Injury to physical or mental health of the mother up to 24 weeks is clause C. And most of the abortions in practical purposes will apply to clause C. Clause D is for the sibling. Please remember D is for sibling, E is for fetus. Okay, so I believe that it is clear to you all. Now I'm going to move ahead with the scenarios. So G2P1 plus 2 at 8 weeks having Down's baby at home. Which clause? Okay, so this is going to be clause D because it's affecting the sibling, right? So yes, all given me the right answer. No, see, don't think of clause C over here whenever they mention something like a Downs baby. So a Downs baby is kind of, you know, it's not like autistic where it is, there is a various bigger spectrum. So that kind of sorts of a Down syndrome baby makes it a clause D. Okay, so having Eisenmenger, you are all correct. It is a clause A. Primary at 7 weeks, unmarried, unplanned conception, emergency contraception failure. Yes, very good. You all are correct in identifying that this is going to be clause C. Primary 12 weeks anencephaly. Anencephaly, so always think problem with the fetus or problem with the sibling. So yes, you all are correct. That is going to be clause E. Okay, so a few book questions we are going to sort. Okay, so the answer to this one is about not continuing this pregnancy because she's not in a relationship because of her university degree. She is in a lot of problems. So this is not confirming with any of the other categories, it is going to be ground C or clause C or category C. Now, this one is a 32-year-old woman with two children. And yes, Rubina, that's like social reasons, right? So you'll find that most of the situations, if you imply them, will come to clause C, like I was telling you. So, 32-year-old woman with two children who is 20 weeks pregnant attends antenatal clinic in South London. Consultant has just told her that earlier investigation have confirmed that the fetus has Down syndrome. She already has one child with Down syndrome and one with autism. She is not sure whether she is mentally, physically, or financially able to look after another child with Down syndrome. She is thinking of having a termination of pregnancy. Now, why this question is a beautiful question, because now you're going to be confused whether it's due to the sibling or whether it's due to the fetus. Now, whoever are telling me E, I'll just tell you that, see, Down syndrome alone is not a, not an anomaly in a way where, it's not compatible with life. Like Edward and Patau, they are Down's babies. Actually, they can live up to a certain life expectancy. Okay, so this is going to be category D. Now, I know now there is one confusion between whether it's category B or category D. And let's see over here. See, the mother is telling that I am not mentally, physically, or financially, I'm not going to be able to look after another child with Down syndrome. So the problem is not about the baby having Down syndrome, not about the fetus having Down syndrome, but it is the problem that the other kids in the family are also having similar sort of dependency and problems, right? So this sort of lines in the question whenever they're telling you a lot of sibling problems are there, and those sibling problems are kind of making it impossible for the mother to carry out, carry on another pregnancy, then it will become clause D. Okay, because it's a sibling issue. Otherwise, if suppose this was a primary mother and she had Down syndrome, maybe the financial constraints would not have been so much for her, right? So that makes it clause D. Give me a thumbs up if you all are, following this. Yes, Amira, E in Downs with certain cardiac anomalies which are making the baby incompatible for survival.
Hi, can I ask a question?
Yes, please.
There is written that she is not sure whether she is mentally, physical, or financially able to look for the kid. So can't it be C plus C?
See, there are even bigger issues over here. So, whenever you're looking at a legal clause, suppose there is a charge of murder, there is a charge of theft, there is a charge of, you know, um, breaking into the house. Suppose a thief has broken into a house and has stolen something and then has also committed a murder. So, whenever we are taking up the clauses and the acts, the first and the most serious thing, of course, we can charge the thief on all these accounts, but the most serious implication will be of the murder, right? So, similarly, whenever any such legal ground is coming in our question, so we are going to take up the more serious problem over here. So over here, the more serious problem is the other kids having the Down syndrome, making it difficult for the mother to continue with the pregnancy because of the financial and the emotional burden she is already stretching herself on. So if it had been a primary mother with first pregnancy, there is this particular implication of a Down's baby. Maybe she could have continued, but she doesn't want two dependent babies. Maybe she's looking forward to a further healthy pregnancy so that the baby later can grow up to an adult individual and support the siblings. So, with this sort of an idea, if such scenarios are given, you have to solve it.
Thank you.
Hello, ma'am.
Hello.
Can I ask a question?
Yes, please.
Okay. If a patient is pregnant of Down syndrome alone, as an indication for termination of pregnancy, it should be class what? Down
So
syndrome alone.
Down syndrome alone, if it is not
Yes.
having any, uh, any major lethal abnormalities. So now they are going to mention whether this fetus with Downs is having any major abnormalities like cardiac defect, which is not compatible with life. Then, of course, it is a problem with the fetus, making it clause E. But if it is going to be a Down syndrome alone with no major abnormalities, now Down's babies are born and they have kind of some sort of a life expectancy as well. So then, if the mother still wants to abort, then it is going to be clause C if it is a primary mother. And that abortion has to be done before 24 weeks because that cannot be a severe, that is not, of course, clause A. That can also not be clause B because it is not a grave or permanent injury giving birth to the Downs baby. Right? So it will not be clause B, but it will be clause C. So you can see how we have
Thank you.
ruled out clause B, how we have
Yes,
ruled
yes.
out clause E. Yes.
Thank you.
Okay, so Rubina has given us a beautiful summary in the chat box. So down baby with previous baby also down is clause D. Down baby with anomaly, clause E. Yes, and down baby can't handle financially is clause C. Right, perfect understanding. So to summarize, um, unborn baby is a problem to the mother due to social stigma, career, relationship, trouble, financial issues, contraception failure. So, this is summarizing everything in total, not only the Down syndrome question. Okay, this is a general summary. So, unborn baby is a problem due to all these reasons, will be clause C. Now, unborn baby is a problem to the mother because the mother has a handicapped or specially abled baby at home. Even it might come like this. Don't get confused then. Suppose Mrs. Adams have come to us. She is having a 2-year-old Down syndrome baby at home. She has conceived again. As the 2-year-old is severely dependent on her, she is not willing to continue the pregnancy. That will also be clause D because the problem is not the pregnancy, the problem is the kid that she has at home who is specially abled. We don't call them disabled or handicapped anymore. Just for your understanding, I have written, we should be more sensitive towards the specially abled people. So, we have to use more sensitive words for them. But just for your understanding, I have written that if there is another handicapped or specially abled baby at home, then it will be, and if she's asking for abortion of a perfectly healthy pregnancy because of because of this baby at home, then also that is going to be clause D. Now, if the unborn baby has as an anomaly that is incompatible with life or will shorten lifespan, that will be clause E. Okay, so if it is clear to you all, we will now move on to NICE guideline on miscarriage. Now, this again is something that has been updated in 2023. Okay, and I'm going to focus on what all are the new updates and certain things about, the most high yield points from where questions might come. So, as because we have seen a tendency of questions driven with images, I would just like to give you some idea about what is the mean sac diameter. Like I told you, which one is the sac, so this one is the sac, and this extent is what is measuring the diameter of the GSAC, right? So, mean sac diameter of the GSAC, you have to take a mean by giving through the sagittal section, also giving through the coronal section. Okay, now over here you can see there is a fetal pole. Can you make it out over here? There is a fetal pole here. There is again a fetal pole here. But this is another mean sac, diameter that they're measuring, but there is no visible fetal pole. So, how is it going to differ? If you find a mean sac diameter of more than equal to 25 millimeter, Please remember two important numbers over here. When you come to the NICE guideline on miscarriage, remember your numbers are 25 and 7. Okay, these two numbers are going to be your friends when you are reading the guideline on miscarriage, 25 and 7. So, mean sac diameter, if it is 25 or more with TVS and you don't find a fetal pole, then you repeat the scan in 7 days. And you know, hundreds of questions you will see in the practice books where the answer is going to be repeating the scan in 7 days. If you have gone through the Janesh Gupta books, if you have gone through the mastering books, you'll find this that there are many, many questions along the same lines. Now, mean sac diameter more than equal to 25 mm using TAS. There is no fetal pole, and then you repeat the scan in 14 days because it's a transabdominal scan. Okay, so 25 is your best friend when it comes to the guideline of NICE, a NICE guideline on miscarriage. So if it is more than equal to 25 and there is no fetal pole, you wait and do a scan in 7 days before declaring that it is a miscarriage. Right? Now, this is the next best friend that you have in this guideline. The next best friend is 7. So if the crown to rump length, now suppose I have shown you earlier in this particular part that what exactly how the development is progressing. This is the G sac which has appeared, this is the yolk sac, and then finally the embryo. So over here we are measuring the sac sagittally, coronally. Okay, so we are taking two cross sections and measuring sagittally and coronally. Over here, you can see one star marker over here, another star marker over here. So this is actually where we are measuring the embryo. That is the crown, which is the head end, because you know the crown always sits on the head. And this is the tail end, which is the rump. Okay, so the rump is standing for the buttocks. So the head to tail end, this entire, diameter is going to be the crown to rump length. We call it CRL. Right? So CRL or crown to rump length is going to be a measurement for the embryo. Of course, it cannot be a crown to rump length for a GSAC. For the GSAC, we have taken the diameters. Is it clear? Is the concept clear to all of you? Give me a thumbs up quickly. A GSAC is going to be a sac. There is only going to be, the measurement, the coronal section and the sagittal section measurement. Even then, they are not going to give you and confuse you with such, sagittal length, coronal length. They're just going to give you the mean sac diameter. But if it's a crown to rump length, then that is going to be an embryo we are talking about. So even after the embryo has formed, after the heartbeat has appeared also, then also there can be problem of miscarriage. You all know that. You've all seen that in your practice, right? So if there is a crown to rump length of more than equal to 7 millimeter using TVS and then there is no heartbeat, you have to repeat the scan in 7 days. If it is more than equal to 7 millimeter using transabdominal scan and there is no heartbeat, you have to repeat the scan in 14 days. Okay? So this is why I told you that 25 and 7 are going to be your best friends when you're going to read the guideline because it's going to solve a lot of questions for you. Now, threatened miscarriage. If there is, now from here, what questions are going to come is how you're going to manage a threatened miscarriage. What is a threatened miscarriage? The patient has come to you with bleeding and ultrasound is showing that things are going on. The fetal heartbeat is present. It's an intrauterine pregnancy. Things are fine as per ultrasound, but she is bleeding. So if there is no history of previous miscarriage, things are fine on ultrasound and there is vaginal bleeding, you can do an expectant management. If the bleeding stops, you can refer her back to ANC, that is antenatal care, the routine antenatal care. But if the bleeding is persisting beyond 14 days or is worsening, then you call her back to the gynecology unit for the repeat assessment. Okay? Because in NHS, these ANCs are at many times run by midwives also. So if the bleeding is stopping, you can refer her back to ANC. If it is persisting beyond 14 days or if it's worsening, you can return her for further assessment to the doctor, to the gynecologist, to the specialist, that is. Okay. So this is only when there is no history of previous miscarriage. What if there is a history? If there is a history of previous miscarriage, now things are serious. Now we don't go about with expectant management. Now is the scenario where we are going to give vaginal, and that is why I've highlighted over here not oral, not intramuscular. It's vaginal micronized progesterone 400 milligram twice daily and continue till 16 weeks if heartbeat is confirmed. Okay, so this is how, where exactly we are putting progesterone for threatened miscarriage. Only if there is a first pregnancy with vaginal bleeding, NHS, the NICE guideline is not recommending progesterone for them. If there is a history of previous miscarriage, everything is fine in the scan, and there is vaginal bleeding, that is only the situation where we are going to put in vaginal micronized progesterone. And that is going to be continued till how long? It's going to be continued till 16 weeks. Okay. So I believe that this data is also clear to you all. Give me a quick thumbs up if you are. Yes. Thank you, Aisha. So now suppose all of this threatened miscarriage was going on, and then unfortunately the patient indeed had a miscarriage. Okay. Now, what is the difference between confirmed miscarriage and threatened miscarriage? Well, in the threatened miscarriage, she was bleeding, but ultrasound was telling that things are going on fine. But if she is bleeding to some extent and ultrasound is telling us, yes, there is no heartbeat, yes, there is no growth. You have done a repeat scan as well after 7 days, still there is no improvement. Means what? It's a confirmed miscarriage. Are you getting the difference between a threatened miscarriage and a confirmed miscarriage? Okay, so the scan results are the only difference, right? So now what you need to do, you can carry out an expectant management, you can carry out medical management, you can also carry out a surgical management. When and where? Okay, if you are going to go
ये
ahead,
लगाओ, लगाए तो उससे चार्ज होता, वो
okay,
चार्ज होता है, ये चार्ज होता है.
okay, I've muted you all. So right, so expectant management is the situation where you have to rule out the risk of hemorrhage, and then only you can carry out expectant management. Expectant means what? You are just waiting and observing, right? So if there is risk of hemorrhage and infection, you can't do the wait and watch treatment. Of course, another criteria is that if the patient is willing for expectant management, okay, then how long do you carry out the management? It has to be continued for 7 to 14 days. If the bleeding is controlled in 14 days, you can go about doing an UPT after 3 weeks. Okay. So if things are settling on their own, you don't disturb it and you ask the patient to come back after 3 weeks. If it's positive, then she returns for assessment. If the bleeding doesn't start or persists or increases after 14 days, then you are going to do a TVS for expectant management. Okay, so that is for expectant. Now, what then? Another option would be medical, another option would be surgical. So, what do we do for medical management? Remember, the chart I have given at the beginning was for willful termination, that is abortion. Okay, willfully terminating your pregnancy. Baby was all fine. The mother didn't want to continue the pregnancy. Over here, this particular mifemizo is for somebody who have already had a missed abortion, right? So over here also we are giving a 200 milligram mifepristone, and 48 hours later we are putting in 800 mg misoprostol, and that can be vaginal, oral or sublingual as per the guideline. Now if the bleeding is controlled, UPT can be done after 3 weeks. If it's positive, you can call her back for repeat assessment. So it's basically the same thing over here in expectant. and again in the medical management. Now, if bleeding doesn't start after 48 hours of misoprostol, you have to reassess. Okay? Over here, if bleeding doesn't start or persist or increases after 14 days, why you're taking 14 days here and only 48 hours, that is 2 days over here? Because this is here where you have done nothing. You're just waiting for things to happen on their own. So you're waiting for 14 days. But over here, you've given medication, but still the bleeding has not started. So you're really worried. So now you have to reassess sooner. So it's after 48 hours. So remember, comparisons like this, small tidbit of information like this, and things are retained better in your brain. And ultimately, in the question, when it comes in the exam, there is no confusion, right? Now,
Can I
another
ask
thing,
a question, please?
yes, please.
If someone comes at 6 weeks with a history of previous miscarriage and she has bleeding, but there is no fetal heart, do you give progesterone given she had a previous miscarriage and she came in with bleeding?
Now, see, she has a previous miscarriage, okay? Now she is 6 weeks and she doesn't have a heartbeat. This will apply, this will take you to this particular last look slide. What is the CRL? Okay, so
Okay.
is it something yet to appear or is it something that is confirmed? So if the CRL is more than equal to 7 millimeter and there is no heartbeat, you have to confirm it with another scan in 7 days. But if she bleeds more before 7 days, if the bleeding increases, then of course, like we do that in our practice, right? If she is bleeding, we always tell her that, okay, you wait, you take the medication, whatever it is, but you repeat the scan, and then we can only confirm if things are following through or not. Now, with the previous history of miscarriage, no heartbeat, okay, and the vaginal bleeding is there. So, if the CRL is not there, we cannot really put her on vaginal micronized progesterone. We just have to repeat the TVS at this point. But this is all as per the NICE guideline and how UK is doing it. So, for answering the question in your exam, please stick to whatever the NICE guideline is teaching us. I know in many of our own practices, we give everything empirically. Like, okay, we give her all the progesterone, all the sorts of progesterone, all the routes of progesterone. Yes, we do that. But when it comes to NHS services and when it comes to answering our MRCOG questions, we have to stick to whatever is written in the guideline.
Thank you.
Okay. So incomplete abortion. Now over here, see, mifepristone is not needed because of course the growth of the baby is not there anymore. Even a part of it has come out only. That is why it is incomplete. So no point of giving mifepristone and only give 600 microgram of misoprostol. Why? Mifepristone is always doing sort of a priming action for misoprostol. Now, since an incomplete abortion, already half of the expulsion has occurred and remaining half is remaining. So, no point in wasting time with mifepristone. We directly give misoprostol. Okay, and that can again be vaginal, oral, sublingual, any of the routes. Surgical management, there is no fixed criteria as per NICE guideline. When do you choose surgical? Okay, so MVA, that is manual vacuum aspiration, it can be done under local anesthesia in an outpatient or clinic setting, or it can be surgical under general anesthesia in an operation theater. Okay, so this kind of summarizes what we had to talk about miscarriage. Now we are coming straight forward to the questions. Patient calls 3 weeks after her miscarriage. She says that UPT is positive. What would be your advice to her? Okay. So the answer to this one, yes. So you're all correct. It is going to be a TVS and it has to be done now only. Right. So the next question. 25-year-old patient having amenorrhea for 7 weeks, ultrasound shows no intrauterine or extrauterine pregnancy. Beta HCG done and repeated 48 hours later, which drops by 68%. Patient stable vitals and pain free with mild vaginal bleeding. Which one of the following is most appropriate for her? So the answer is going to be UPT after 3 weeks. As you can see, because the beta ACG has dropped less than, by more than 68%, confirming that it is subsiding on its own, whatever was the pregnancy of unknown location. We cannot really say it's an intrauterine, extrauterine, whatever it was, an ectopic, or it was an intrauterine pregnancy, whatever it was, unknown location, it is just subsiding on its own. Patient is also all stable, all good, no symptoms. So you have to just repeat an UPT after 3 weeks. Which one of the following USG is correctly diagnosing a miscarriage? Now, confusing question with many numbers, but you know which number is your best friend? Okay, so the answer to this one is going to be A. MST 25 mm with no obvious yolk sac or fetal pole. That is going to be the only indication of a confirmed miscarriage. Okay, so because in B, there is a CRL of 7 mm with evidence of cardiac activity. So, of course, there is no problem there. This over here is 200 IU. This is 1500 IU per L. So, these are all pregnancy of unknown location. We don't know, but that we cannot say as a miscarriage, right? So be very clear when you understand the numbers because 25 and 7 are your best friends. So 20-year-old, 12 weeks gestation, has a 2-day history of vaginal bleeding and lower abdominal pain. Ultrasound shows a 25 fetal pole with absent fetal heart rate. Okay. So pelvic examination reveals the cervix to be 4 centimeter dilated with bulging intact membranes. Which one of the following is the most likely diagnosis? And the answers are coming in. Right, it is going to be inevitable abortion or inevitable miscarriage. Mrs. XY, primigravida, 9 weeks pregnant. 9 out of 40 means 9 weeks pregnant. So, because the total duration of pregnancy is 40 weeks. So, if they put it like that, in the stress of the exam, 9 on 40, what does it mean? So, don't get worried. It's 9 weeks pregnant. And she has a confirmed diagnosis of missed miscarriage. She had 2 transvaginal scans a week apart. We have discussed all the options with her. She opts for medical management for missed miscarriage. She is extremely anxious about the discomfort associated with the procedure and has a low pain threshold. Okay? Which of the following is the most appropriate medical management for her? So, when they say, you have to read question very carefully. Medical management. So, even if they have given some sort of anesthesia in the answers, you are not going to opt for that because they're asking for the medical management. Anesthesia. See, NSAID for analgesia is different than anesthesia, okay? So it's a missed miscarriage. And misoprostol with NSAIDs, that is kind of the best possible option over here because MIFE is 200, MISO is 400. This MISO answer is also suboptimal. I know why you have gone with this particular answer, and that is why I've put this question over here. But look over here, it's 200 mg MIFE with 800 mg MISO, right? So very simple question, very simple concepts. But when it comes to very close options, things go missing. Now see, she is extremely anxious about the discomfort associated with the procedure. So they are kind of putting in NSAID over here and making life simple for you to choose. Okay, so that is why the answer to this one is going to be misoprostol 800 with NSAIDs for analgesia. Okay, you are the on-call gynae registrar. The sonographer from the early pregnancy assessment unit wants to discuss a patient's result with you. She has just performed a transabdominal scan on a 28-year-old woman who is 16 weeks pregnant by date. Scan shows a fetal pole with a 7 mm CRL, no fetal heartbeat. Patient has declined a transvaginal scan. Sonographer wants to know when she could book this patient for a repeat TAS. Very simple question. See, such a long paragraph given. Very simple answer. So yes, you all are correct. So I have driven home the point when to repeat. TVS is 7 days, TAS is 14 days. Another question. A woman who is 11 weeks, 3 days pregnant, complaining of abdominal colic and an attack of brisk vaginal bleeding. Repeat ultrasound confirmed fetal demise. You diagnosed inevitable miscarriage. She is considering expectant management. How will you counsel her? So when such questions are coming, what we need to do? So she is at high risk of bleeding because it's a advanced pregnancy, advanced first trimester pregnancy, you may call it, because it is more than 10 weeks, right? Up to 10 weeks, the risk of bleeding was not that much. That is why we told them below 10 weeks, she can do it at home, right? So small things, see how you have to correlate. Below 10 weeks, we are telling you can do it at home. Over 10 weeks, we are not allowing that. Why? Because there is a risk of bleeding. So you have to explain to her at this point that she is at a high risk of bleeding. This is the most important point. Okay? It is not A, it is going to be C. Now, you would say, why not A? See, at 11 weeks, beyond 10 weeks, with inevitable miscarriage, sending her home with the advice of, waiting and watching is not the best thing to do. So you have to tell her, see, over here, in expectant management, what was the criteria? Rule out risk of hemorrhage, late first trimester pregnancy. Okay? You have to rule out if she has coagulopathy. No, it's not there. You have to rule out if she is Jehovah's Witness. No, she isn't. You have to rule out, is it a late first trimester in pregnancy? Yes, it is. So expectant is not the best choice for her. Are you following this? No, it's not, it's not about whether you're doing it at home or otherwise. It's about expected management is safer done in early pregnancies. In late first trimester pregnancies, expectant Jehovah's coagulopathy. These are risk factors. Okay, and you have to explain those risk factors to the patient and try to modify whether if she wants a medical management or something else other than expectant, because expectant, B is out and out wrong option. Expectant management is the best option. No, it is not, because it's a late first trimester abortion. Okay, if that one is clear, we are moving on. A woman who is 8 weeks pregnant complains of vaginal bleeding. Ultrasound scan shows a crown to rump length of 7 mm but no heartbeat. You advised her to come for a follow-up scan after 7 days. She expressed her concern that waiting that long may harm the pregnancy or her health. How will you counter her concern? If you go through all the options, your answer becomes very easy. Yes, it is common sense. The answer is going to be A, because rest of the answer, options are all out and out very weird. You cannot ask the midwife to talk to her. Of course, it's not sounding right. She's concerned. You're in front of her. You now cannot delegate her to the midwife. Beta HCG measurement will confirm. No, you cannot do that in NHS. There is no rule of doing beta HCG test at random as you please. You can only do it for monitoring of an ectopic pregnancy. Give her a leaflet explaining the unit's procedures. No, it should not be like that. Offer her termination. No. So that is the A is the right answer over here. Now we are coming to another part that I wanted to discuss with you, FGR. Because that's a recent guideline, number one. That's a difficult one. Lots of modifications have occurred, and you people find it kind of a bit difficult to negotiate. So if you just give me the next 20 minutes of your undivided attention, I promise to make FGR easy for you all. So are you all with me? Can you all give me a thumbs up? Yes, Aisha is giving me a thumbs up. Who else is there? Amira, yes. Thank you so much. So, moving on. Thank you, Mary. So, we will be moving on with FGR. So, again in FGR, two important numbers are 3 and 10. Why is that? So, we are going to compartmentalize three things, three levels of difficulty in FGR. First difficulty is which one is FGR, which one is SGA. There is the primary problem which lies with students. Okay. What are the parameters? How do you define? Okay. Which are the normal Dopplers, which are the abnormal Dopplers? So that is going to be the first thing that we are going to discuss. How to define FGR. That is difficulty level 1. Difficulty level 2 in FGR is how do you monitor? They have a very big chart that they have given over there. And with that particular chart, you all get confused, but it's a very, lucid chart if you just follow today's explanation, and things will be pretty easy for you all. So, how would you monitor an FGR? That's the next thing. And the third level of difficulty is what is the cutoff? When are you going to actually deliver an FGR? Now, mostly I have seen questions coming from your level 2. That is, how frequently are you going to monitor? Mostly I have seen questions which are asked from this particular parameter. But if you understand everything thoroughly, things will be pretty easy. So we are going to learn number 1 about definition, number 2 about how to monitor, number 3 about when to deliver. Okay, so the first thing for definition, now we are at level 1. right? So the first discussion we are going to have is about the definition. So 3 and 10, these are the two best friends that you have in FGR. So what is AGA? AGA stands for appropriate for gestational age. So if a baby's height or size is between 10th and 90th centile, okay, then it's an appropriate for gestational age baby. That baby is fine. SGA is when the fetal size is below 10 centile. Then what is LGA? You can all figure out it is beyond 90th centile. Okay? So, what is actually FGR? FGR, if there is a fetal size or AC. So, whenever we are taking one criteria to define FGR or SGA, and that criteria is going to be the abdominal circumference. We know we can monitor the size by abdominal circumference, the head circumference, the femur length, all of these are parameters, right? But if they ask you what is that one sole parameter which is most important out of these three, that is going to be abdominal circumference when it's come to defining FGR and SGA. Okay? Let me mute you all. Okay. So now, FGR, if you're finding a baby who is out and out below third centile, you don't even look at the Dopplers. You don't even look at any other parameter. If it is less than third centile, it's out and out FGR. Okay? Or if it is less than 10th centile with Doppler problems. So now it's very clear to us that any baby less than 10th centile can be FGR or SGA. If it is SGA, it is only less than 10th centile. If it is less than 10th centile with Doppler problems, it is FGR. And if there is the EFW, which is or the AC, which is below third centile, then it directly qualifies as FGR. We don't even look at the Dopplers now. Okay? So this is where the number 3 and 10 are important. If you look at the last look slide of mine, you are now pretty sure why now numbers 3 and 10 are important. There's another characteristics of static growth where there is a no change in EFW or AC 14 days apart. This is just for theoretical interest. We are not classifying or discussing this anywhere later in the guideline. This is just for your note that if there is no growth over 14 days, we call it static growth. Now we move on to the next part. So look at the following criteria. Which of the following is not defining FGR in previous pregnancy? So it is birth weight below 5th centile in a previous pregnancy because that cutoff would be 3rd centile. Okay, so now we are kind of sure about our understanding of the definitions. If you are able to answer this question correctly, I'm confident now that you have understood how to define FGR and how to define SGA. Please read the question carefully. Which of the following is not defining FGR? I believe one of you have given me the wrong answer just by not looking at the question correctly. So Yusra, it is not defining FGR, okay? Okay, so right. So we have all understood the definition. Now, another part of the definition I told you, if there are Doppler abnormalities. Now, if suddenly in the question they give you about certain Doppler readings, now you'll all be panicking in the exam that ma'am had told us Doppler abnormalities, but we did not really know what exactly is the Doppler cutoff. We don't know that. So, how do you know that it's a normal Doppler or an abnormal Doppler? So, your magic number is 95. Okay. So, how is that your magic number? So, you see, the left-hand side of this last look slide, you already know the fetal size or EFW or AC below third centile, or if there is a fetal size below 10th centile with Doppler abnormalities, and these Doppler abnormalities are, there can be Doppler problems with two Dopplers. Uterine artery Doppler, umbilical artery Doppler. Okay, so remember this whenever we are giving you the magic number of 95 and whenever we are telling you Doppler problems, it can be with the uterine artery, it can be with the umbilical artery. Okay, as far as the definition of FGR is concerned, don't bring in middle cerebral artery in the picture over here. This is for defining FGR. Okay, you have to compartmentalize your brain. Middle cerebral artery is coming in the brain sparing effect of the FGR. All of those complicated theories, nobody is going to ask you over here. Middle cerebral artery in our part 2 preparation is coming in Rishas. Okay, in the ABO incompatibility, right? So over here, when we are talking about Doppler, we are talking about the abnormal Doppler, we are talking about the magic number 95. The two Dopplers we are talking about are uterine artery Doppler and abnormal umbilical artery Doppler. So what is this abnormal uterine artery Doppler? PI above 95th centile. What is PI? I'm coming to that later. And or, okay, abnormal umbilical artery Doppler, PI above 95th centile. So now you know why it is the magic number of 95. So if both of them are present, then also it's FGR. If at least one of them is present, then also it is FGR. So if the uterine artery PI is more than 95, then we are going to call it FGR. Okay. So now tell me something. If the estimated fetal size is on the 20th centile, uterine artery Doppler is more than 95th centile. EFW 20th centile, uterine artery Doppler more than 95 centile. Yes, Aisha has given me the right answer. Again, repeating the question for all of you. EFW 20th centile, uterine artery Doppler more than 95 centile. Is it FGR? Right. What about the rest of you? Are you all following? So the weight has to be, don't get yourself lost into the Dopplers only. Please remember that the weight is the primary criteria. Along with that, the Doppler abnormalities are there. Then it is going to be a reflection of FGR. So apart from abnormal umbilical artery Doppler, you have heard about words like absent end diastolic flow, reversed end diastolic flow. I'm coming to explaining all of these in details with you. So absent end diastolic flow, reversed end diastolic flow, all these flows are flows in which particular artery in the body? These are all the flows about the umbilical artery, not the uterine artery, okay? So whenever we are going into the classification, then it's not only about having an abnormal umbilical artery Doppler with a PI above 95th centile. It can also be absent end diastolic flow. It can also be reversed and diastolic flow. So this one chart is your last look slide on definition of FGR. Okay, you memorize this chart and you're sorted for life, right? So this is how it is going to be important. This is how 3, 10, and 95 are your best friends in defining FGR. So definition part is now done. Now another small classification. Types of FGR. So if it's early FGR or late FGR, the differentiation criteria is 32 weeks. If it is less than that, it's early. If it is more than that, it's late. Can you tell me, based on whatever knowledge you've gathered till date in your practice, which one is worse, early or late? Which one has a worse prognosis? Very good, Aisha. So always, 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 an early FGR is more troublesome, is got worse prognosis than a late FGR, right? So this much you can actually deduce from whatever patients that you have seen, because if it's an early FGR, if the problem with the growth is starting really early, there is one thing we are very worried about. We are worried if it's a chromosomally normal baby. Okay, because if the growth problem starts that early, we are worried if it's a congenital anomaly or if there is some sort of a chromosomal problem with the baby, right? So early is the worse one. So again, EFW or AC less than third centile, or umbilical artery and diastolic flow absent in diastolic flow, or EFW or AC 10th centile with uterine artery PI more than 95th centile, or umbilical artery PI more than 95th
लाइव में
centile.
खत्म नहीं होना है लाइव
Just
bueno
now, what about late FGR? If the gestational age is at or more than 32 weeks. So remember, over here also, the equal to sign is at 32 weeks for late FGR. So today we have learned about two equal to signs. We have learned about anti-D equal to sign. That is the moment the equal to sign is at 12 weeks, we have to give anti-D. Okay, so quick revision on that too. And we also learned in late FGR, it is more than 32 weeks, or at 32 weeks, we call it late FGR. And of course, it has to be in absence of congenital anomalies. Rest of the things are almost same, except that the criterias are slightly different. But don't worry, they don't give you a lot of questions on how to differentiate between the two. But in case they give you, some new, updates or new questions are there, then just go through this slide once, that what all are the criteria to define early and late FGR. Okay, so moving on, umbilical artery Doppler. Over here, I'm going to emphasize on what we have learned about PSV, EDF, and PIRI. Okay, so we frequently come across these words. PSV. We have learned about PSV in which particular artery? MCA PSV, right? We were talking about MCA PSV, and I just now told you which guideline we were talking about MCA, middle cerebral artery. We were talking about that in RH incompatibility, right? So what is, anyways, any waveform will have a peak systolic velocity and diastolic velocity. I'm explaining all of that, but just so that you people can compartmentalize information in your brain, because we are 3 weeks from the exam. PSV will be mentioned with MCA when it comes in the RH incompatibility guideline. EDV, end diastolic velocity, is going to be mentioned in the FGR guideline. It will come with umbilical artery Dopplers, right? So, peak systolic velocity, suppose your heart is pumping the best possible flow of blood. Just a systole has occurred, the contraction of the heart has been a full contraction, and the blood level shoots up, and this is where there is the peak systolic velocity. Okay, so the systole has started, have gone up to here. This is the peak systolic velocity, or PSV. Then the heart muscles are relaxing. The blood level in the vessels are falling. The blood level in the vessels are falling. And this is diastole. In diastole, the blood in the vessel are not pumped. They are just very relaxed. And this is where the levels are lying now, in diastolic velocity. So peak systolic velocity and diastolic velocity. Time average velocity is the difference between the two peaks. Not important for us from the MRCOG part 2 perspective. Okay, we are not, appearing for the FMF exam over here, so not important that way. So this is PSV, this is EDV. Up to this concept is clear. Then what is pulsatility index? Pulsatility index is the difference between PSV minus EDV upon TAV. Okay, time average velocity is the difference between the two peaks. What is resistive index? That is PSV minus EDV upon PSV. Just learn these two figures as theoretical knowledge. Application of pulsatility index will be there when it comes to FGR. Okay, so we have learned about umbilical artery PI. What is PI? Pulsatility index. What is pulsatility index? That is the PSV minus EDV upon the TAV. What is CPR? CPR is the Doppler index of MCA upon the Doppler index of umbilical artery. This also is important from the theoretical knowledge. Now over here you see, this is a normal flow. This is the PSV, peak systolic velocity. This is the end-diastolic velocity. Absent end-diastolic flow means what? The systole has occurred. Then the heart is in diastole. And suddenly there is no flow in the blood vessel. There is an absent end-diastolic flow. AEDF, absent end-diastolic flow. Now, the baby was receiving blood and suddenly there is no further flow. Is it a good thing or a bad thing? Of course, it's a bad thing. So now the baby is not getting any flow when the mother is in diastole. This is all these systoles, diastoles we are talking about is the mother's heart. And the mother's heart was working fine, but the baby is not getting blood. That is absent end diastolic flow. Because there is no flow, as you can see over here, no flow between these 2 points. Now, what is even worse? Reversed end diastolic flow. So it is going to be a systole, and then in diastole, now instead of the mother providing blood to the baby, some of the baby's blood is coming back to the mother. So there is a flow reversal, reversed end diastolic flow. Now that's even worse, right? Because the baby is already, in a compromised position. On top of that, blood is now flowing from the baby to the mother. So we are even now more worried. Okay. So this is about the PSV, EDV, TAV, PIRI. Now the last look slide comes. How we are going to monitor. So before we go into that particular last look slide, is it clear up to here? Is it clear? Okay. So now we go into the last look slide of monitoring. Okay. So I told you now we from level 1 we have gone to level 2 difficulty of monitoring this FGR baby. So now by definition we have a FGR or an SGA and how we are going to monitor the baby. So if it's a low risk factor situation, we just go by the symphysiofundal height. Okay, if it's a moderate risk factor, now these green yellow box are very important. If it's a moderate risk factor, it's anomaly scan, and after that 32 weeks onwards ultrasound every 4 weeks. If it's a high risk factor, you have to do a uterine artery Doppler and then ultrasound based on the findings. Now, when we are telling USS, it means ultrasonological scan. USS. What exactly are we looking in that USS? We are looking at umbilical artery. Okay. If we are finding a problem with the umbilical artery, then we are going ahead with ductus venosus or CCTG. Now, CCTG stands for computerized CTG, because whatever CTG we are interpreting, we are deciphering and giving the result are all manually done. Computerized is actually even recording the very minute millisecond of the ST variations. So STV and all that, we are coming to that slowly. So just in a broad spectrum, if you look at this, right? Yes, Aisha, it's about Stan. So if you look at the entire broad picture, if it's a last look slide where you have to just remember this thing first. Low risk factor, you just go about doing a symphysiofundal height measurement. Nobody is going to put you questions from here. Questions will come from moderate risk factor, where you do an anomaly scan and then 32 weeks onwards ultrasound every 4 weeks. In the ultrasound, you look at the umbilical artery. If there is a problem with the umbilical artery, you move to ductus venosus or CCTG. If it's a high risk factor, you go with uterine artery Doppler and then ultrasound scan based on the findings. Again, in the USS, umbilical artery, and then if there is problem, you go with ductus venosus and CCTG. So we are coming to the next part, which is this particular chart. So now we are a bit is eased out, because we know green, we know that you will go about with serial measurement of SFH. We know with moderate risk factors, we will go about with serial ultrasound from 32 weeks every 4 weeks until delivery. But if it's a high risk factor, then we have to carry out the uterine artery Doppler. If things are okay, then we go about with an ultrasound scan from 32 weeks every 2 to 4 weeks. If it's a normal uterine artery Doppler, but the baby's EFW is less than 10 centile, we are worried. We will do a serial ultrasound scan from 26 to 28 weeks until delivery. If it's an abnormal uterine artery Doppler and EFW is more than 10 centile. Okay. Now we will carry out the ultrasound 28 weeks onwards. Why? Because at least the fetal weight is not compromised, only the uterine artery. Between this block and this block, see, if it's the uterine artery which is normal but the fetal weight is lesser, if the fetal weight is lesser, we are more worried. So we start earlier, 26 to 28 weeks. If it is abnormal Doppler with EFW at least that is more than equal to 10 centile, we start from 28 weeks and every 2 to 4 weeks until delivery. Then abnormal uterine artery Doppler along with the AC or EFW less than 10 centile. Then you have to send the patient to fetal medicine. Why? Because now you're worried about congenital abnormalities, chromosomal abnormalities and all that. Okay, so this in a nutshell is the chart, and this is the last look slide for the chart. But again, another trick that you have to learn over here, you have to memorize about the risk factor, which all are the moderate risk factors, which all are the high risk factors. So please note over here the most important points. If it's a previous SGA, that will be a moderate risk factor. If it's a previous FGR, that is going to be a high risk factor. So if the mother, Mrs. Adams, have come to you, her last baby was an SGA, we in this pregnancy monitor 32 weeks onwards. But if the last baby was FGR, then we carry out the uterine artery Doppler, and based on that, we will go about monitoring further. Okay, so if any of these diseases are there, the maternal medical conditions, then it will be a high risk factor. Okay, so Aisha has a point that some questions mention the weight of the baby without mentioning the SGA or FGR. See, this guideline has changed a lot over the years. That is why I think what you're looking at is you're looking at the old questions, but if they formulate in the exam nowadays, they will go as per the new guideline. So it is very important. Even the factors, the risk factors also have changed very recently. Even 3 years back, the risk factors were also different. Now the risk factors, there is a lot of shuffling. So don't worry, they are going to mention whether it's a previous FGA, FGR, or SGA. Now, what if there is a previous stillbirth? Stillbirth, unfortunate, but you have to look if it is a stillbirth AGA or a stillbirth SGA. Now, out of these two, stillbirth plus AGA means the baby who had stillbirth was appropriate for gestational age. It was about the previous pregnancy they are talking. Previous pregnancy, it was a appropriate for gestational age baby who had stillbirth. That will be a moderate risk factor. If it's a previous stillbirth with SGA, like the previous stillbirth with the baby who was stillbirth was a SGA baby. So now that will be a high risk factor. Okay, so these are the small tidbits that I wanted to highlight, where the moderate risk factors are, where the high risk factors are. Remember, SGA and stillbirth with AGA will be moderate. Remember that FGR or stillbirth with previous SGA will be high risk factor. All the medical conditions will also be high risk factors. Right? So now, this is one straightforward question from one of the TOG articles. Let's see if you can answer this. So you all know this one. This one is 15 weeks. Now this is your next question. What will be the next appropriate step if offered in severely SGA fetus with structural anomalies and considered in non-anomalous fetus before 23 weeks of gestation? So I've color coded so that you understand, so that the English does not become very confusing. But in the exam, nobody is going to be that generous. But still, I've become very generous and I've color coded. So if it is offered in severely SGA with structural anomalies, and you can consider in non-anomaly babies before 23 weeks of gestation if there is SGA. What is that particular thing? Yes, you all are correct. You have to offer invasive testing, because if it's a severe SGA and there is structural anomalies too, you're worried about a chromosomal abnormality. If there is a non-anomalous fetus before 23 weeks of gestation, then also you're worried about abnormalities. So how do you aim for delivery? You have to aim for delivery. Now we are entering the third part of it. Okay. So we have discussed about the definition. We have discussed about the monitoring. Right? Now we are looking at when to deliver. Is it clear up to now? Then we are going to go into delivery part of it. So whenever you're going to, the baby is already compromised. It's an FGR baby. Now you are worried about when do you want to deliver, right? Because you don't want the baby to have become a stillbirth. You don't want the baby to become an IUD. At the same time, you don't want to deliver the baby early also and make the baby suffer in ICU for a longer time, right? So it's a risk of intrauterine compromise against risk from iatrogenic premature delivery. So over here, let's just solve a case together where, I'll take you through the walk on how to interpret the charts of FGR, how to apply the knowledge of when to deliver. So, you know that in FGR there are two scary charts. One of the scary charts is this one. The other scary chart is this one, right? So we will discuss all these charts. Don't worry. If you can master these two scary charts, then your FGR is solved. So, Mrs. AG, 25-year-old, primary. Low risk on combined FTS. Anomaly scan showed a single umbilical artery. Rest of the factors were normal. Came for routine ultrasound at 25 weeks as had pain in abdomen. Now, the ultrasound was showing AC on the third centile. Okay, how would you approach such a case? So, see, this is not a question you are going to expect in the exam, but this is where, how we take forward the discussion so that the things settle in your mind. So, whenever you're telling that AC on the third centile, we know one thing. What do we know? It's FGR or SGA. It's FGR, right? Not even needing to look at the Doppler. We know it's FGR. Now we know after definition there was another chart which I talked about early FGR or late FGR. So can you tell me whether it's early or it's late? Look at the scenario closely. She came for routine ultrasound at 25 weeks. Right? So it's early or late. Right, brilliant. So this is early, right? So now this is what the 25 weeks chart is looking like. Now, I want you all to zoom to this part of it. This is a growth chart. You can see HC in millimeter, head circumference, AC in millimeter, abdominal circumference, FL, right femur length, weight in grams. Okay, so all of these factors are getting plotted, right? So again, look at these particular lines. This is the 95th centile line, this red line which is going. This is the green line which is the median, and this is the 5th centile which is going. Okay, this particular parameter, the head circumference, is lying on the left, on the red line. This parameter from the 5th centile, it is even dropping down. It is now come below 5th centile. Okay, so this parameter is dropping down. Now, nobody is going to give you charts like this and tell me and ask you that, okay, it has come to this. Can you tell me what centile it is here? They are not going to ask like that. They're going to provide you over here. So you see, if we look at this, that what is the EFW? EFW is on second centile. You can see this is the 5th centile line that is going, and the EFW is below that. Right? So EFW is on second centile. So far, whatever we have gathered that this line is on 5th centile, femur length is less than 5 centile. This one is also from 5, it has gone to below 5. This one is also below 5. So you have no confusion that it is an FGR. So are you understanding how these charts are actually getting interpreted? Right? So give me a thumbs up if you all are clear in your concepts. How the charts we are interpreting. Thank you, Amira. Thank you, Salma. Right. So now look over here. So we are convinced that it's FGR. You can see they have given that the umbilical artery PI is more than 95th centile. MCA PI they have given. Why? Because when you're assessing the baby like this, you have to also understand about brain sparing effect and all, but all of that will be done by the fetal medicine specialist. We don't need to worry for MRCOG part 2 answers, okay? So let's not worry about MCA right now. DVPI. DV, what is DV? Ductus venosus. That ductus venosus PI is on 85th centile, uterine artery PI more than 95th centile. So now we know that from this entire information over here, we know this entire picture is an FGR. We knew before also, because this one line gave it away. But if they are not mentioning any of this and they're directly giving you this particular chart, I think you'll be able to understand now that it is FGR, right? So what will be your diagnosis? It's FGR. Early or late, it is going to be early. So I have not given the answers. I feel that it is very basic and you can all be able to work it out. So this is exactly a difference between late onset, early onset FGR, just for your reading, just for your interest as to why I say that early is even more worse than the late onset. Uh, so just have a read through this, need not memorize. Okay, so common causes of early onset FGR. It can be aneuploidy, fetal infections, early uteroplacental insufficiency, like serious problem with the placental development, right? And maternal undernutrition. So these are the most important causes, and all the causes are not really good. They are bad causes, right? What are the early predictors? How would you know that this baby is going to land up with early FGR? If the PAP-A is less than 0.4 or at 0.4, if it's low PLGF, placental growth factor, then if it's a high alpha fetoprotein, this PAP-A, this AFP, PLGF, all of these are getting done during the combined FTS. Okay, and these are predictors which can, not the PLGF will be done in the second trimester, but PAP-A, alpha fetoprotein, they can be done in the early trimester, and they can serve as predictors of which all babies might have an early FGR. What are the ultrasound markers? You can find the uterine artery PI more than 95. There can be problem with the cord insertion, marginal insertion or velamentous insertion, single umbilical artery, or these are all the predictors of early onset FGR. So now we were talking about this early onset FGR baby, and you remember at what week she came to us? She came to us at 25 weeks. She had pain abdomen. We did the scan. We were not happy with her growth. Okay. Now she has come to us again after 2 weeks, that is 27 weeks. Because, of course, why did she come? Because we have asked her to come. Because we have found a problem. We have found an early FGR, so we have asked her to come. After 2 weeks, 27 weeks, now the EFW is on first centile. Umbilical artery, it was previously showing more than 95 pi. Now it is showing reversed end diastolic flow. Look over here. If you see, this is the umbilical artery. Can you make out these are the limbs? And over here, there is a cord-like thing. There is a red part. There is a blue part. Means what? You know in the umbilical cord how the artery and the vein are the twisted ones together, right? So this is where they are taking the measurement for the flow. And the flow is telling us that there is a reverse end diastolic flow. The blood is flowing from the baby to the mother back during diastole of the mother. Now, let's look at the scan picture. Scan picture, you see, this was the EFW at 25 weeks. So remember from this particular chart where the EFW was? This was your 25-week EFW. You see the number 25? This is 25 weeks. Now, where does it lie today? It is at 27 weeks. So this is your 28 cutoff. It's at 27 weeks. And it is on the first centile. So it is still continuing below the fifth centile, and from second centile it has now become first centile. So don't think from here, since it is slightly tilted upwards, doesn't mean it has increased. Okay, because it is in relation to the centile line. That is why I have given this particular graph over here. Don't randomly assume that because this line has increased like this, doesn't mean it has increased. It means it's on the basis of the centile. So you measure the distance from the line to the blue point over here. You measure the distance from the line to the blue point over here. This line is shorter, right? From the red line to the blue point. This line is longer from the red line to the blue point. That means there is a further dip. Earlier, the EFW was on second centile. See, on second centile, the gap between the red line, the centile line, and the blue dot was lesser. Now, the gap between the blue line and the center and the red line and the blue dot is more, which means that it has further increased. That is why I've given it over here, so that you don't make the common mistake of thinking that this is actually going up, this is improving, yay, we are doing better. No. Now, in the question, are they going to put you like, confused and worried and looking with a magnifying glass at the question paper at what is going up, what is going down? No. They're going to make your life simple. They're going to put you a data. So now the AFW is on first centile. So we know it was on 25 weeks. It was on second centile. Now it's on first centile. So it has gone down. With umbilical artery RADF, what is the next step? So when we have, remember my last look slide on monitoring, when we have looked at the umbilical artery and when we have found a problem there, where are we branching forward to? What other artery can we look at now? Don't say MCA, because MCA is 100% for RH incompatibility. Very good, Aisha. It's DV or CCTG, right? So look over here. Can you tell me which organ is actually the ductus venosus artery? In which part of the body it is there? Liver. Very good. So can you make out this is a cross section of the abdomen? Okay. And this is the liver. There is the ductus flow. These are the triads in the liver, and that is the ductus venosus. So you can see over here, this is the umbilical cord artery they have taken. This is the ductus flow they have taken. Now you may ask, madam, can we expect so many complicated pictures, and are they going to only put pictures? Not like that. I sincerely hope, and I don't think they're going to put questions like that, because it's not for fetal medicine specialist. But I'm just giving it out to you so that you have some understanding and concept, and questions do not come as out of the blue for you. So now this is the ductus venosus, that flow that we are looking at, and we are looking for the A wave. If the A wave is there, we are relieved. If the A wave is absent, we are worried. Okay. Also, if suppose now they are telling you either we go for the ductus venosus or we go for the CCTG. Now, why these two options? When to choose what? Can you tell me when do we choose what? Answer is very simple. You choose CCTG if it is available in your center. You choose umbilical artery, ductus venosus Doppler if that is available in your center. So you can choose either of them depending on what facilities are there in the center, right? So if you go through the first point over here, early FGR. So early FGR, if it's between 24 to 25 weeks, or 26 to 28 weeks, or 28 to 31 weeks, right? And we find that there is an absent end-diastolic flow, reduced end-diastolic flow. Doesn't mean we are going to jump at the patient and deliver the baby, because you remember we have to weigh against prematurity and IUFT. So we have to derive at that cautious balance. So if it's 24 to 25 weeks, then we have to provide, look at the cursor that I'm pointing on the screen. 24 to 25 weeks, we provide individualized care. 26 to 28 weeks, we provide delivery if DV, ductus venosus A wave, is absent, or STV is less than 2.6. How do you remember this number? We have to remember this number by remembering this number. Okay, so just remember this number STV. If it is less than 2.6, that means short-term variability. What is short-term variability? You say that I know about baseline variability, but what is short-term variability? Now, short-term variability is something that only CCTG, computerized CTG, can pick out, because it's very intricate. Are they going to put us questions and graphs from computerized CTG? No, because they don't expect you to solve what computers are solving. We have computers for that. They will only give you CTG. They are for interpretation of CTG as per the NICE intrapartum monitoring, but they are not going to give you computerized CTG to interpret, because that is the job of the computer. They are going to give you the data that the STV is less than 2.6. They're going to say like the STV is 2.2, suppose. So you know that this STV is less than 2.6, and the baby, if it is between 26 to 28 weeks, you have to deliver if the STV is less than 2.6 millisecond, that is ms. 29 to 31 weeks, you deliver if the DV, if the ductus venosus A wave is absent or STV is less than 3. Now, you have to deliver by 32 weeks if REDF, that is reversed end-diastolic flow in the umbilical artery, and you have to consider delivery from 30 weeks onwards. You have to deliver by 34 weeks if absent end-diastolic flow in the umbilical artery, and you can consider from 32 weeks. Why? Because reversal, it means it's even worse. So mandatorily deliver by 32 weeks. Since absent is slightly better, so you can, the criteria cutoff is also up to 34 weeks, right? So this entire gray box is for early FGR. Is it clear up till now? Give me a thumbs up quickly if it is clear up till now, if you're all awake up till now. Very good. Lots of thumbs up. Thank you so much. Okay. So after that, 32 to 33 weeks. So the moment we touch 32 weeks, where is the equal to sign? On 32 weeks for late FGR. So now we are happy. We are happy because now it is a late FGR. Now things are going to be simple. So if it's 32 to 33 weeks, 6 days, and there is absent end-diastolic flow, see, up to the arrow is going up to here. So you find the umbilical artery problem, you find absent end-diastolic flow, reversed end-diastolic flow up to 32 weeks. Then the next step would be DV, A wave, or STV. Okay? DV, if the A wave is absent, or STV, if it is less than 3.5, you deliver. Now, what is the major change that is happening beyond 34 weeks? Beyond 34 weeks, you don't go for the ductus venosus. It's 34 weeks above, you're finding this umbilical artery problem, you monitor twice a week CCTG. Over here, there was a choice between twice weekly CCTG, DV. Over here, you only monitor twice weekly by CCTG. Do not go for DV, ductus venosus, beyond 34 weeks. Why? Because it's not going to be that sensitive to give you proper data. That is not a good choice to be done beyond 34 weeks. Okay, now you have to consider the delivery by 36 to 36 completed weeks, like 36 to 36 plus 6 weeks, if the PI remains more than 95th centile. You may have to deliver earlier if the STV is less than 4.5 or if there is absent end-diastolic flow. So please note over here, absent end-diastolic flow, if it happens, then beyond 34 weeks, you deliver the baby. Right? No point of waiting further. No point of even waiting for reverse end-diastolic flow. Reversal and all those pulling and pushing was to pull through till towards maturity. We were all trying to pull the baby till 34. Over here, the moment it touches 34, that means it's a pretty mature baby who can be managed outside. Now, this again is a thing that is going to vary country to country. And in NHS, we are happy with 34. So, you have to deliver if it is absent and diastolic flow only if the baby is already 34 weeks. Right? So, after that, well, if it's a term pregnancy more than 39 weeks, you have to deliver SGA by 39 weeks. Okay? And you have to deliver between for 37 to 38 weeks, 6 days. You have to deliver by 37 plus 6 weeks of gestation. Okay, so this is in a nutshell about the management plan of this particular FGR guideline. So is it clear to all of you now? How are you going to plan the delivery? So we know that this was the baby, 27 weeks, the ductus venosus flow is there, the A wave is there, and my center has only got ductus venosus flow. So I bring the baby back, bring the mother back when? Today is a Wednesday, maybe it is already Thursday in certain parts of, certain of your countries. But suppose today is Wednesday, and today this is your report. The ductus venosus A wave is present. It's a 27-weeker early FGR. Today is Wednesday. When would you bring back the baby? So we know we have to do a twice a week ductus venosus, right? Lenovo, you're overloaded. Don't worry. Almost done. Almost done. We just have one tiny bit of EMQ to solve. So just remember like this. If you're too crowded, maybe you can go and listen later to the recording, or later also I'll again be coming back to this in the boot camp with more questions. So don't worry. So just remember now it's 27 weeks. Today is Wednesday. 3 days later, I'm again going to bring back the mother and check the umbilical artery Doppler. The ductus venosus Doppler. Right? Now, no point in doing the umbilical artery Doppler. We are looking at the ductus venosus Doppler. A wave is present. Fine. We are so happy. We have let her go. Again, 3 days later, we bring her back. Again, to the umbilical artery. The ductus venosus Doppler. Right? So we keep on from 27 weeks to 27 weeks, 4 days, to 28 weeks to 28 weeks, 4 days. Like this, we are pulling with reversed end diastolic flow. What is my end point? How far do I want to pull a reversed end diastolic flow early FGR? How far do I want to pull an umbilical artery reversed end diastolic flow early FGR? 32 weeks? At best, we can start considering from 30 weeks. So this is my target. This is my target. But suppose 27 weeks, 4 days, then that was also fine. But then in 28 weeks DV, the A wave is absent. Now what do I do? 28 weeks, ductus venosus, A wave is absent. Now what do I do? Very good, Saima. I appreciate your answer. I'm not going to give it away now because that is my next question. Okay. So, do you give steroids and deliver? Do you get magnesium sulfate and deliver? Right. So, always look at, the possible options in the EMQ, right? So, all these factors you have to keep in mind when you answer the questions. So, let's see. This is about a few questions, a few EMQs from managing intrauterine growth restrictions, because of course before it was called FGR, it was called IUGR. Then this is an old book question from where I've taken this EMQ. So this is the question. I think it's better if you all take a screenshot of this particular scene. We've got only a few more slides to go, so come on, buck up. More energy I need in each and every one of you. So take a screenshot of the screen in front of you and give me. Okay, so you've taken a screenshot. Let me take you to the question over here. So see, let's 20 so it's a 27-year-old second gravida referred by her midwife for small dates on palpation at 28 weeks. BMI is 18, FTS was negative. First pregnancy, she delivered a 2177-gram baby at term. Ultrasound shows all fetal parameters less than fifth centile with normal Doppler indices. Single most appropriate intervention. So this is a 28 weeker. So yes, the next thing that we can do is going about monitoring the baby, right? So of all the options, you have to do a serial growth scan, fetal umbilical artery Doppler study, because it's still at 28 weeks and we don't deliver at 28 weeks. We have to go on monitoring the baby. Number two, 19-year-old primary gravida with a BMI of 30 reports after her first FTS, first trimester screening and NT, which shows a low PAP-A. Now I told you low PAP-A in FTS is a predictor for early FGR. Right? So, with that idea in mind, what are you going to do? These are all book questions, C, but your approach totally changes when you understand the questions and the concepts behind it. So, I can understand your tendency to go on mugging the recalls, but please properly assess your knowledge, because that is extremely important. If a slight twist happens in the question, you will entirely be off chart. Okay, so because there is a low PAP-A and it's a FTS scan now, if I take you, see, if I take you to this chart, I told you low PAP-A is a predictor for early FGR, right? So I'm taking you to the chart and I'm highlighting you over here. Current pregnancy, low PAP-A. Right? This low PAP-A in current pregnancy is a high risk factor. So where is my chart taking me to? It's taking me to uterine artery Doppler. This is an old practice question from one of the books. So now your prerogative would be to do a uterine artery Doppler for her. Right? Right. Let's go to the next question. 28-year-old second gravida attends antenatal clinic after anomaly scan at 20 weeks, which shows symmetrical IUGR and normal fetal anatomy. Fetal bowel appears echogenic, uterine artery Doppler is normal. She has not had any antenatal visits earlier in the current pregnancy. First pregnancy ended with spontaneous miscarriage at 16 weeks. So Now you see, if I take you to the chart over here, if you see echogenic bowel, if you see over here echogenic bowel, you would again find that it's a high risk factor, which directly takes us to the uterine artery Doppler, right? It's a high risk factor. But look what is different in this particular question. There is another important point. Now you would say that, madam, for the last one also uterine artery Doppler, this one also uterine artery Doppler, two answers back to back, same option. So now you see it's a symmetrical FGR, normal anatomy, but she has not had any antenatal visit before this. So there is no FTS done, right? The first pregnancy also ended with spontaneous miscarriage at 16 weeks. So, total overall, we are thinking about what? Mm, why are you thinking about infection? See, the first pregnancy, there was a spontaneous miscarriage, okay? Now, in this pregnancy, no checkups have been done till now. Fetal bowel appears echogenic. Echogenic bowel can be due to Down's baby as well, and into a lot of chromosomal anomalies as well. Okay, so IUGR, symmetrical IUGR. All of this means we need to do an amniocentesis for her. Right? So that would be your right answer. Is it clear to all of you? Now, the next question, if it's clear to all of you, give me a heads up. Otherwise, I'm happy to elaborate. But you need to solve all your doubts now. It's only 3 weeks to the exam. Right. Brilliant. So 34-year-old primary gravida present at 35 weeks gestation with reduced perception of fetal movements. She is a non-smoker with a BMI of 27, clinically small for dates baby. Ultrasound reports fetal biometry uniformly less than second centile and amniotic fluid index of 6. Umbilical artery Doppler shows a reversed and diastolic flow. Taking you to the options. Please remember something important I have shown you before. If it's 35-weeker pregnancy, 35-weeker pregnancy, right? And this diastolic flow problem is there. It's not even absent. It's a reversed and diastolic flow at 35 weeks of gestation. Is there any rule of doing DV, etc., etc.? No, Aisha, the cutoff is not 32. The cutoff would be 34, right? So now what we are doing, we are looking at delivery. Now, another situation. Do we give betnisol, betamethasone beyond 34 weeks according to the antenatal corticosteroid guideline? No, right? So all of these betamethasone options are also out. Do we get magnesium sulfate? No. So that also gets rules out. Now the delivery. Okay. So it's already a reversed and diastolic FGR baby. That is why induction is not the proper answer. The proper answer would be a cesarean section. Now, whether category 2 or category 3. Andy, yes, right answer. No, not category 1. Category 1 is like for vasa previa. Okay, so it will be a category 2 cesarean section. So this is, the correct key, MOAF, as we have discussed. So I hope that your concepts are,
Can
a
I
bit
ask you
more clear.
something, please?
Yes, please.
Since since we're going for a cesarean, would you offer steroids, or there will not be enough time for the steroids to work?
No, because if we are, either ways, it's more than 34 weeks, 6 days. Now, it's not a elective cesarean section. We are, I think you're somewhere confusing that up to 39 weeks we can give for cesarean section by maternal choice. But because it is 34 weeks, 6 days beyond that already. So, as per the antenatal corticosteroid guideline of the GTG, we are good to go. We don't need to wait for the
Okay,
steroids to happen. Otherwise, we'll end
thank you.
up with an IUST.
Thank you.
Okay. Yes, Aisha, that is what I'm telling. CS before 39 weeks, if it's an elective cesarean section, if it's a maternal indication, yes. CMV, yes, ecogenic bubble would be there, but other choices will also again be there. Like there will be certain problems with the brain, calcifications, and all of those features. So either ways, even it's a symmetrical FGR, so that is why we have to go for the karyotypes. Now, so the MRCOG boot camp is just round the corner. I hope this session was helpful to you all in terms of clearing out your doubts, in terms of your answering of the questions, how to approach the questions. Thank you, Aisha. I'm glad that you're looking forward to the boot camp where we are going to solve more scenarios, where we are going to provide more last look slides. And how I plan to take Educator session is by, making it exactly accessible to each one of you so that, you know, um, all of your doubts are cleared in that particular session, whatever time you're spending in the class itself, because we cannot really waste further time in making things more delayed. EMQ Bootcamp, that is up next from the 15th of July with Dr. Hassan as well. And with a success history, we are going to show you all of our, MRCOG crash course exam candidates feedback this time. Okay, so this is all the positive reviews that we had. Thank you all for the amazing feedback. I know many of you are here who are or have been in my classes before, been in the sessions before. Those of you who have not been, I hope that this session was insightful to you, would help you clear some difficult concepts in the exam, right? So, yes,
So the
furthermore,
boot camp will be every day.
sorry.
We will have a session every day for the next 10 days.
Yes, if you're going for our EMQ course bundle
Yes,
as well as the bootcamp bundles, then it will be, back-to-back sessions every day. And if you are opting for our 40% special discount, it will be a special discount on the QR code. It's a gift for all the webinar attendees today. Okay, this is the QR code which is there on the screen. The timing of the classes, that is going to be from the same timing as today, 3:30 p.m. GMT for all of you. I hope this class is there with you. Okay, it's 3:30 p.m. GMT for the bootcamp classes. For Dr. Hassan's classes, I think Ikra from Team Ed Exam Expert can guide you better. You can directly scan the QR code over here and avail the 40% discount. I want you all to have the last moment preparation going in a way that it becomes more fruitful for you, makes you really easy to pass all your exams. Okay, so thank you everyone. Good night, bye, and I Just hope, I just wish and pray that you all succeed and you all pass with flying colors. Okay? Thank you so
Thank you
much,
so much.
everybody. Okay, so we have the EMQ classes. The EMQ classes starting from 15th of June, they will be on 2 p.m. GMT, Dr. Hassan classes. And my bootcamp classes are starting from 20th of June, 5 days back to back. And that's going to be from 3:30 p.m. GMT. Thank you so much. So without further ado, if you want to pursue this particular course, you can directly scan the scanner that is available on the screen and go ahead with your bookings for the session. Thank you so much, everyone. With that, I'll be signing off for now. A very good day to you all and all the best for your exams.